Pooja?
Just be comfortable. We'll start the session in a while.
हाँ, मैं भेजूं?
Pooja, I think we should start the session.
Yes, ma'am. Good evening, everyone. On behalf of Ankura Hospital for Women and Children, I welcome you all in this knowledge sharing session. So to take this session further, I would like to invite Dr. Khalil Khan.
Yeah, thank you, Pooja. Good evening, everyone. On behalf of Ankura Group of Hospital for Women and Children, I would like to invite you all for this session. So today we have a very dynamic speaker, Dr.Reena Mathew. She has completed her MBBS and MD from Goa Medical College, and following which she has relocated to Hyderabad, and she has done her fellowship in pediatric critical care and have been working in pediatric critical care for more than 5 years now. I hope you will have a fascinating experience listening to her. She'll be speaking today on delirium. We all know that delirium is often frequent in children, but is often ignored. So because of our ignorance, it leads to lot of problems in form of increased hospital stay, hospital cost, increased duration of mechanical ventilation, even mortality. So it's such an important and often much ignored topic. So over to you, Reena. So let's start now.
Thank you, sir, and good evening to everyone. Thank you for joining me today. So give me a minute, I shall share my screen.
और उसके बाद फिनल गन कितना दिया था 5 में दिया था
All right, so very warm welcome to you. And I'm sure all of you can see an image on your screen right now. Each one will interpret it differently and describe it differently. Some may say it's just an abstract, some may say it's similarly, also being described by various diseases, either in acute infusion or psychosis or in acute toxic psychosis. Delirium in pediatrics was identified only in 1935 by Leo Cannon. And in 1955, another psychiatrist, Bleuler, just shrugged it off, saying that delirium in pediatrics is not at all important because children are so often delirious. It took another 50 years to prove him wrong. And this is shown by the fact that in the last decade or so, there has been growing awareness of the clinical importance and prevalence of this delirium. Now, how does it present? Let me share with you a story of a child, a 9-year-old girl who was developmentally normal. She was diagnosed with dengue and presented to us with sudden loss of consciousness on day 5. Her MRI was suggestive of ADEM, so she was intubated because of forced insurrection and started on neuroprotective measures. She was ventilated and started on the sedation protocol of opioids and benzodiazepines. Pulse methylprednisolone was given to her. However, we were not able to extubate her within the first 7 days because of forced insurrection. And finally, after 10 days, we succeeded. Luckily, she did not have any hospital-acquired infections. But it's when we extubated her that we realized she had some behavioral disturbances. She was agitated within 6 hours of extubation, disoriented, and sleeping throughout the day but wouldn't sleep at night. By the next day, she began swearing at her parents, and her parents were appalled at her behavior. They didn't even know that the child knew these words. But however, by 3 days, these symptoms subsided. She was coherent, except for her sleepiness. A 5-year-old child, again developmentally normal, who presented with polytrauma, severe TB, with brain injury. He was intubated and required multiple vasopressors to manage his hypotensive shock. During this course, he was ventilated and again started on the same sedation protocol, extubated after 4 days. Unfortunately, this child developed Acinetobacter sepsis. But lucky for him, his MRI was just suggestive of diffuse axonal injury, grade 1, which has a very good prognosis. But we noticed that this child, post-extubation period, also had lethargy, apathy, and wouldn't recognize parents the first 24 hours post-extubation. Neither was he wincing during needle pricks or any other nursing stimulation. After 2 days, He used to have a blank gaze. He wouldn't maintain eye contact with the doctors or the nurses, but he would only maintain eye contact with his mother. And he had started showing single word responses to his mother. It took about 4 days for his behavior to be normalized. So we need to understand that this burden or this problem of pediatric delirium is real. And this was shown by an international point prevalence study done by Traub et al., who defined a prevalence of 25% in their ICU, with increased 40% of delirium in mechanically ventilated. And it's not only the prevalence that we're worried about. Delirious children have increased PIC length of stay, fold increased risk, and also increased duration of mechanical ventilation, thereby bringing all the complications of ventilation and hospital-acquired infections. And after controlling all the confounding variables, delirium was identified to be a strong and independent predictor of mortality, increasing the risk by fourfold. Hence, we cannot overlook this problem anymore, and we need to understand how to approach pediatric delirium and identify this so that we can improve the critical care outcomes. Coming to a definition of delirium, DSM-5 has not stated a separate definition in pediatrics. However, delirium is nothing but an acute but fluctuating disturbance of attention or awareness with a change in cognition. And this disturbance should not be explained by any pre-existing neurocognitive disorder like mental retardation, syndromic abnormalities, developmental disabilities. And this disturbance should be as a result of underlying medical illness or its treatment. So the onset is acute over a period of few hours or days. And by fluctuating, I mean that the symptom will not be the same in the morning as it is in the evening. In the adults, it is typically described as sundowning. That means the symptoms worsen towards the evening, the end of the day. However, such sundowning has not been shown in pediatrics as of now. So coming to understanding the pathophysiology, why does it occur like this? There are three main hypotheses put forward by researchers. The first and the most commonly widely accepted hypothesis is that of the neurotransmitter hypothesis, which means delirium was attributed to either the presence of acetylcholine deficiency or a dopamine excess. This would cause defective in the integration and processing of the sensory impulses or sensory stimulation, leading to an impaired motor response. Also, when you have any systemic inflammatory state or any infection, there's a massive cytokine release, as we all know, which further causes disruption of the blood-brain barrier, leading to local ischemia in the brain and neuronal apoptosis, thereby again altering the neurotransmission. In post-operative patients, however, it has been studied that even a short duration of desaturation or hypoxia in the intraoperative period or in the postoperative period, or in patients of trauma, there is excess of dopamine because of the inhibition of the catechol O-methyl transferase enzyme by the reactive oxygen species produced in this state. And normally, catechol O-methyl transferase enzyme is required for conversion of dopamine to norepinephrine. And since this conversion does not occur, there is excess of dopamine, which ultimately, effectively, all of this lead to the common pathway of altered neurotransmission. But it's not only dopamine and acetylcholine. There are other neurotransmitters also involved in delirium. And that's the reason why we have the fluctuating course of delirium, which means that you could have delirium secondary to GABA excess or GABA deficiency, glutamate excess or cortisol excess, which is seen in any stress state or inflammation, surgeries, stroke, excessive cortical use, serotonin deficiency or serotonin excess, again seen in critical illness, and our very own cytokine and dopamine. All these neurotransmitters work in different proportions, thereby leading to altered neurotransmission. So delirium can be found in two phases. Either it could be early onset, that is delirium within the first 72 hours of PICU admission, and this would mostly be attributed to the predisposing risk factors or pre-hospitalization risk factors, for example, severity of illness. Whereas delirium identified after 72 hours of hospitalization is mostly attributed to the iatrogenic risk factors. And these are the factors that we need to study and try to mitigate. Delirium is usually transient or temporary, mostly lasts for a period of 2 days. It can vary between 1 to 52 days, but doesn't mean it's a small problem just because it is a temporary issue. And those children who have stayed in the hospital for beyond 72 hours, it has been shown that they can get a second episode of delirium. That means if they've already recovered and they are 48 hours delirium free, if there is any new insult or a new infection or inflammation, they can get delirium again, and that is definitely a problem. As shown in this study, that after 5 days of hospitalization, you see that the delirium incidence has increased rapidly from 17 to 50%. So we need to reduce the PICU or the length of hospitalization. There are three main types of delirium as we know it. You have the hypoactive type, which have the negative symptoms of inattention, inability to focus, disordered sleep, lethargy, slow speech, and apathy. Then you have the hyperactive type, which have all positive symptoms of aggressiveness, agitation, speech incoherence, restlessness, and hypervigilance. A very small proportion of pediatric population may get delusions and hallucinations, but it's not very frequently reported. And then you have the mixed variant, where the symptoms of hypo and hyper fluctuate throughout a period of 24 hours. Now we need to identify that the hypoactive delirium has been studied as the most prevalent type, followed by the mixed, and hyperactive usually only contributes to around 8 to 10% of the existing delirium in the population. What we need to see is the red flag. So look for a child who's inconsolable. Look for a child who's also inappropriately calm. So a child who allows you to prick, allows you to put various catheters without resisting is not a good patient. That is a delirious patient. And also a child who does not maintain eye contact, consistent eye contact, which he used to do earlier, is also a cause for concern. So at follow-up, we've seen these children and we had identified the child A to be a mixed type of delirium and the child B to be hyperactive. Now, the child A's parents complained that she was increasingly fussy, she was behaving like a 3-year-old, throwing temper tantrums, and if she wouldn't get what she wanted, she would start biting and be very stubborn. So the father was a little confused as to why his child was acting like this. And with the child B, when he came back after 1 week, the parents said that they noticed that the child had difficulty in execution of tasks. So if the child was asked to collect the newspaper from the door, the child get confused, he would not go, which he used to do earlier. Or even wear his own shoes. So slipping into his shoes used to be a task for him. He would put in one shoe and leave the other leg half outside. So he would not complete the tasks which were given to him, which he used to do earlier. And he also started having a temper, suddenly would start crying when he wasn't given even something as simple as a chocolate. So why did this behavioral disturbances occur? We need to understand that delirium is not without consequences. And it has been shown that delirium has long-term cognitive impairment in these children. So impairment in visual and spatial memory, impairment in executive function, in problem-solving behaviors, and even emotional lability has been reported. One study reported that these children have post-traumatic stress disorder even up to 3 months post-discharge. And we've already seen that the length of hospitalization, the PICU stay, mechanical ventilation is increased in delirious patients, thereby also increasing the risk of further infections, metabolic disturbances, and mortality and morbidity. In our resource limited country, we need to understand that delirium also increases daily and cumulative costs. So the cumulative costs are increased by 85%. This study is from a developed country. However, I'm sure that the burden in our country would be much, much more. So to tackle this problem, we need to understand the risk factors. Traub and Silver, in the largest multi-centric observational prospective study published till date, where they studied 1,547 children and identified a delirium prevalence of 27% in this, also studied the possible risk factors and their association to delirium. And they found out that those children who were younger, so age less than 2 years, or or those children who had more severe illness, the probability of mortality being higher with respect to the PIM2 scoring. Those who had developmental delay and those who were mechanically ventilated were at a higher risk of developmental delay as compared to those who were not. And some modifiable risk factors were identified. Amongst them, the most prominent is exposure to benzodiazepines, which increase the risk of delirium by 5-fold. Anticholinergics, narcotics, antiepileptics, and vasopressors all increase the risk of delirium by more than 2-fold. And physical restraints was also identified to as being a risk factor by increasing the risk of delirium by 4-fold. So this brings us to the fact that since there is significant association being shown amongst these risk factors, you can divide the risk factors in two types. Either they're predisposing risk factors or modifiable. Now, the predisposing factors are the ones that the patient already presents with. They're already pre-existing. They cannot be modified. So a child who is younger than 2 years who has an immature developing brain and therefore there'll be increased alteration of the neurotransmission. A developmentally delayed child is also at risk. Similarly, increased severity of illness because of the cytokine storm. So these are the factors that we cannot modify. But what we can probably look at is excessive exposure of anticholinergic, benzodiazepines, narcotics in our ICU, use of physical restraints, and prolonged PICU stay. And we can avoid excessive stimulation by opting for cluster nursing in our ICUs. Looking at the burden of anticholinergics in a little bit more detail, Mayberg, in a cohort of 90 children who underwent cardiac as well as neurological surgeries, showed that these children, in the first 5 days in the post-operative period, developed delirium with an incidence of 33%. And amongst those who developed severe delirium, they noted that those children who were on multiple anticholinergic drugs, who had a mean anticholinergic score of 3.5, were the ones who had severe delirium. Whereas those who had lesser number of anticholinergic drugs, lesser mean anticholinergic drug score, had a lesser risk of developing delirium. When they studied these anticholinergic drugs individually, they realized that those children who had received a higher cumulative doses of midazolam or fentanyl, ranitidine, and furosemide, all of which have very low anticholinergic drug scores individually. But however, when they studied that these children, over a period of 5 days, had exposure to increased cumulative doses, their risk of delirium had increased significantly, and these were the ones who presented with severe delirium. And anticholinergic drugs are not new to our PIC. As shown here in this figure, most of commonly used anticholinergic drugs or drugs which have anticholinergic activity like steroids, vancomycin, morphine, midazolam, even furosemide and antibiotics like piperacillin, these are very commonly used in any ICU across the country. It's not a single drug which can increase the risk, but it's also the cumulative risk of multiple anticholinergic drugs used in the ICU, which will increase this burden in the ICU and is directly associated with pediatric delirium. So we need to rethink our strategy and we need to look at all the drugs and the polypharmacy that we are giving in the ICU for each patient and see if we can choose any alternatives. Coming to the relation of RBC transfusions with delirium. Nellis, in her nested retrospective cohort study, showed that there was 30% instance of delirium in those children who were given RBC transfusions within 72 hours post-transfusion. And in a multiple logistic regression model, she was able to demonstrate a dose-response relationship, where she showed that the risk of delirium increased with increasing doses of transfusion. So the risk more than doubled if you gave 15 ml per kg of PRBCs as compared to 5 ml per kg. But the limitation of this study is that definitely it's an observational prospective study. There was no control that they could compare to. They have not studied the other blood components, only PRBCs were studied. But however, the advantage of this study is that they had control for the confounding variables of severity of illness, sedation use, developmental disabilities, and demographic factors in this chain. So we need, in this era of restrictive blood transfusion, restrictive fluid boluses, permissive hypotensive strategy in polytrauma, we need to also think about reducing overall transfusions in the PICU to prevent pediatric delirium. So why is it then vastly diagnosed if there is so much of research which has proven significant association of risk factors, and why are we not looking at it more clearly? That's because there is lack of awareness amongst physicians and pediatricians as well as ICU nurses regarding the prevalence of this problem, the various screening modalities available, and also the treatment modalities. Secondly, as we've seen that the incidence of delirium is more in children less than 2 years, and these are the children with vast developmental variabilities who haven't established effective communication yet. So they're not able to tell about the signs and symptoms. And most of the symptoms in this age group are subtle and they overlap with pain syndromes or a drug withdrawal syndrome or any other distress. So you can have the similar symptoms if you have an extravasation of IV lines as in delirium. So it is a little difficult and it's a little complicated, but it can be simplified with the help of a five-pronged approach. So the dictum should be that every patient who is admitted to the PICU should be screened for delirium at regular frequencies using routine delirium screening with the validated bedside tools. And if you get a positive score for delirium, then you need to look at the underlying causes. Most often it could be an infection, inflammation, a new onset organ dysfunction, hypoxia, or any of the metabolic disturbances. Most commonly, hypoglycemia and hyponatremia. These are the two most common metabolic disturbances attributed to delirium. Once you have already corrected the causes, then you need to rule out differential diagnosis of pain syndrome or iatrogenic drug withdrawal and look for modifiable risk factors, see if you can reduce the burden of benzodiazepines and anticholinergics, and then move on to focus environmental and non-pharmacological interventions. But before you identify delirium, which is a fluctuation in your awareness and cognition, you need to objectively evaluate what is the level of consciousness or the state of arousal in this patient. And in most of the observational studies in the last decade, Richmond Agitation Sedation Scale has been used to objectively state what is the level of consciousness of the patient. And this is a very well-validated state in adults as well as pediatrics. To assess for delirium, you need the patient to be arousable. You cannot assess for delirium in a deeply sedated or an unarousable patient. Hence, a patient who has a score of -4 or -5 on the RASS scale will not be able to be screened by the validated screening tools. However, a patient who has a score from -3 to +4, this is the range where you can then go on and apply your validated screening tools. So first, identify what is the level of consciousness or the level of arousal, whether he's drowsy, sedated, or moderately sedated, or whether he's aggressive and combative, and then move on to using your screening tools. So what option do we have in identification of delirium? There are four most commonly used and validated screening tools. The Pediatric Confusion Assessment Method, or the PCAM ICU, also has a newer update, which is the Preschool Pediatric Confusion Assessment Method, also called as the PSCAM ICU. Now, this scale is basically an interactive scale which assesses the cognition. So it is not an observational scale. For this scale, you will be, in an older child, you'll ask some questions and you expect a response. And in a younger child, you give a stimulation and you'll expect a response. So the limitation here is that you'll be able to identify delirium only at that given point. You won't know if the child was delirious before your assessment or after your assessment. So it's a single point assessment and examination. And hence, the European Society of Pediatric Neonatal Intensive Care has given it a grade B recommendation, although it has a very good sensitivity and specificity. The next tool is the Pediatric Anesthesia Emergence Delirium. Now, this was developed by pediatric anesthetists to identify emergence delirium, which would occur secondary to withdrawal of anesthetic drugs. This would last for a period of 45 minutes to 1 hour post withdrawal of anesthetic drugs. And it's a very benign form of delirium, doesn't leave any long-term consequences. If the symptoms of agitation and aggressiveness are uncontrollable, then you can probably use dexmedetomidine for sedation. So this was not really used as a routine screening tool in PIC, but widely used in the post-op population. where I have two observational scales, that is the Cornell Assessment of Pediatric Delirium and the SOSPD scale. Now, amongst these two, the Cornell Assessment of Pediatric Delirium, or the CAPD scale, has been validated and has shown criterion validity with a good sensitivity and an acceptable specificity. And the European Society has given a grade A recommendation to use it as a validated screening tool for delirium. The cutoff score for a positive delirium is 9, and it can be used in the age group ranging from 0 to 21 years, and also can be used in those who are developmentally delayed. So coming to a little bit on CAPD, let's see it in detail. CAPD is a simple scale which can be performed bedside. It just takes 2 minutes to complete, and it can also be done by nurses. It has just 8 questions, which you have to ask yourself when you're observing the child, and score from 4 to 0. The maximum score is 40, the lowest score is 0, and any score more than 9 is a positive score for delirium. Now, it significantly assesses these consciousness, cognition, psychomotor activity, orientation, and effect based on each of these questions. And CAPT has been assessed to show a good under the curve in the receiver operated graph of 0.93, which makes it an excellent tool for diagnosing and detection of delirium. It has a very short learning curve, so you can train the nursing staff also to use this. And since it is an observational scale, it helps identify delirium over a period of time. So it is not a single point of assessment. But once you get a higher score, a score of 9 and above, before you jump to the diagnosis of delirium, you need to rule out the differential diagnosis, and you also need to look for the underlying illnesses. So look for pain. See if the child is having an extravasate IV line or the urinary catheter, which is not necessary, is causing him pain. See if you relieve these problems, whether the child is getting better or not. And look for iatrogenic withdrawal syndrome or withdrawal of opioids or benzodiazepines, which usually should happen after 5 days of infusion, but can also happen earlier in younger age group, where you will get excessive sympathetic symptoms of vomiting, you get fever, sweating, diarrhea. And you'll also have similar symptoms as delirium, like agitation, disordered sleep, and irritability. So before you jump to the diagnosis of delirium, just look around and rule out a differential diagnosis. And once you have diagnosed delirium, you have pharmacological and non-pharmacological interventions, of which the most important are non-pharmacological interventions. And these circle around the fact that you need to maintain a very favorable and familiar environment for the patients to allay their fear and anxiety. So please ensure that there is constant presence of the parent to help the child, make the child more comfortable. Ensure that you have a proper day-night lighting schedule in your ICU. So keep your lights on during the day, or preferably you open your blinds and allow the natural daylight to come to your ICU. And at night, you switch off the lights or use a dim light, so that the child has a similar schedule as he had at home, and he gets familiarized with the environment. Use favorite toys, blankets, familiar photographs, or familiar music, sounds, voices. So this will also allay fear and also reduce pain. Educate your staff to speak to the children at regular intervals every time they see them and reassure them to improve their orientation. Involve your parents, because the parents are going to be by the bedside 24 hours, and they'll be able to identify smaller changes in behavior, and they'll be able to tell you if a child is improving, or responding or not responding to your therapy. So involve them and help them help you in managing this child. Stop the drugs that are not necessary, which reinforce delirium, and mobilize these children early. Amongst the pharmacological, we have very few options. But what's more coming into the scene of late is dexmedetomidine, which could either be used as an adjuvant or individually for analogous sedation. Most of these sleep disorders can be corrected by use of melatonin, which has been shown to be safe, and dexmedetomidine can work as a sedative as well as an anxiolytic in these patients. However, none of these drugs are FDA approved, and these drugs need to be used only when the non-pharmacological interventions are not able to subside the symptoms. Amongst atypical antipsychotics, the most commonly studied and used and the safety profile which has been established in pediatrics is the quetiapine. However, this also has not been FDA or DGCI approved. And when would you initiate antipsychotics? You have a large number of antipsychotics, but you need to initiate antipsychotics only and only when the symptoms of delirium, of hyperactive or hypoactive, are not controlled by non-pharmacological interventions. These symptoms will cause a risk to the safety of the child, of the caregiver, the nursing staff, and patients around them, especially when the patient is severely aggressive, pulling out on the ET tubes, on the lines, and also when your psychiatrist you bring on board and confirm the diagnosis of delirium, and he also assesses and says that you need to use antipsychotics in these patients. So it's only then that you start initiating treatment with atypical antipsychotics. If it's a severe case with severe symptoms and you need to use IV medication, haloperidol is used, but it is not without side effects. QTC prolongation, extrapyramidal symptoms are seen very commonly. Hence, the oral drugs, that is risperidone, olanzapine, quetiapine, are more preferred. Amongst this, quetiapine can also be used in those children who have hepatic failure. So it is a much more safer drug. Am I still audible?
Yes, Reena, go ahead.
Yes, ma'am.
Okay. Okay. So coming to our cases, as we've seen that the child A had a CAPT score of 16, but on day 3 when the symptoms subsided, the CAPT was 5, which was consistent with the delirium diagnosis. This child was only managed with environmental modifications and discharged on melatonin for the disordered sleep. Whereas the child B had a CAPT of 12, and on day 4, his CAPT had reduced to 3. But he required dexmedetomidine infusion for 1 day. So what's the consensus on dexmedetomidine? Again, this is just an observational prospective study, but Sperotto in a recently published, this was published as early as July 2020, the PROSTEX trial has shown that in the post-operative children, 163 children who were studied, it was shown that the comfort behavioral score and the withdrawal assessment tool after 24 hours of dexmed infusion had reduced markedly. So these scores are basically indicative of the level of pain and the level of drug withdrawal. And within 24 hours of dexmedetomidine infusion, the scores had reduced significantly. Also, dexmedetomidine showed a drug-sparing effect by reducing the dose of opioid, benzodiazepine, propofol, and ketamine required to maintain sedation with these groups. Dexmedetomidine was also used singly, individually, in about 14% of these patients, and shown that it was a good analogous sedation for those children who were on the ventilator for 5 days in the post-operative period. It has also been used as a facilitator for extubation and also used for prophylaxis of drug withdrawal or treatment of drug withdrawal syndrome. Dexmedetomidine was used for a mean duration of 108 hours in this, and they found out that the doses between 0.4 mics per kg per hour to 0.8 mics per kg per hour were most effective and devoid of hemodynamic side effects. In the 9% of patients that they saw hemodynamic side effects in this population, the most common side effects were bradycardia and hypotension because dexmedetomidine is essential sympatholytic. However, these side effects were managed just by dose reduction and they did not need CPR or any inotropes to manage these effects. And it was seen that these population were the one who had higher doses, who received higher doses of more than 1.2 mics per kg per hour, and also who received a loading dose of 1 mic per kg per hour over 10 minutes, who developed side effects. So it is a rather safe drug. The efficacy and the safety was established in the study if you use a dose of 0.4 to 0.8 mics per kg per hour, because it provided adequate sedation, good amount of anxiolysis, mild analgesia, and sleep, which was similar to the endogenous sleep in the stage 2 non-REM cycle. So dextromethorphan is being increasingly used in ICUs to replace benzodiazepines and opioid sedation, thereby reducing the anticholinergic drug exposure. So if you put all of this together to formulate a simple clinical pathway that can be used at the bedside so that we don't have to worry about all the different causes and risk factors, we can come to a simple pathway which is shown by Kearney. So as we said, anticipate and proactively look for delirium in every patient who's admitted to your ICU and start initiating delirium prevention measures. These measures could be either physiologic measures where you normalize the bodily functions by giving adequate nutrition, hydration, promote your regular bowel bladder habits or routine that the child had at home, and minimize the use of tubes, lines. So do not use catheters where it's not required, central lines and arterial lines if not required. Maintain a sleep hygiene pattern. So promote day-night schedule in your ICU strictly and provide good lighting during the day, low lighting at night so that you can establish a healthy sleep pattern and avoid overstimulation. So all the procedures should be clustered together so as to provide cluster care and minimize interruptions. And from day one, promote mobility, even on ventilated patients. So involve OT and physiotherapy from day one. The pharmacological intervention that can be used in this group are you assess your sedation goals every day. So every time you see your patient during regular rounds, assess the need for sedation, avoid over-sedation, avoid polypharmacy, look for the number of drugs which are having anticholinergic effect in your prescription, monitor and prevent drug withdrawal. So try to take off these drugs as early as possible before 5 days. If the patient is not able to sleep properly, consider melatonin and try to replace benzodiazepines and opioids with dexmedetomidine for sedation. The environmental factors also are very important. So you optimize patient orientation either in an older patient by the nurse itself or in the younger patient, the parent can be by the bedside to speak calmly, clearly, and reorient the patient frequently, and minimize the noise in your ICU to less than 45 decibels, reduce the clutter, create a familiar environment, and for older children, you display a visible clock and calendar. Once you've done these measures, then you need to ask yourself, are these patients continually assessed for delirium and routinely screened? If no, then look for any acute change in the mental status or any behavioral disturbance which could be similar to delirium. And if yes, then look for the level of sedation by using the RASS score. If the RASS score is between -3 to +4, then you can move on to screening with the help of a CAPT scoring or PCAM or PSCAM ICU. If the score is significant and the result is positive for clinical delirium, then you need to go looking for underlying causes. If the score is less and all of the child is significantly sedated, then you please assess your sedation goals and continue ongoing screening and prevention. Once you have got a significant score, you need to move on to the algorithm for clinical assessment and management of delirium. So at this point of time, you may want to consult a psychiatrist and work up for most common etiologies and underlying illnesses. If you are still not able to identify the source, you can consider neuroimaging to look for the intracranial process. But the most common causes would be either hypoxemia, infection, sepsis, seizures, any new intracranial processes like raised ICP or subdural empyema, electrolyte imbalance, and immunological disorders. So correct these, identify these, and ensure that the remaining physiological interventions of normalizing body functions, promoting day-night routines, and mobility are maintained. With respect to pharmacology, look aggressively to minimize benzodiazepines and opiates in your unit. Minimize the polypharmacy, use dexmedetomidine, and at this point of time, consider antipsychotics. If the patient is extremely agitated, you're not able to control the patient, is causing risk for the environment of the ICU as well as safety of the patient is at risk, you'll need to consult a psychiatrist at this point to start your antipsychotics. And environmental measures should continue as is, along with reducing physical restraints and engaging the parents and family members by giving them written material and increasing awareness regarding pediatric delirium. So once this is done, you need to continue to monitor for resolution of delirium signs and symptoms. You may need to give it at least 24 to 48 hours after initiating any atypical antipsychotic for any improvement in symptoms. If the symptoms are improving, well, you're happy. But if the symptoms are not improving, then you need to further look for other underlying causes and ensure that is taken care of. You may need to probably slowly increase the dose of the atypical antipsychotics or use another antipsychotic. So this is simply put brief clinical way of how we can in our daily business. So coming to the problem again, pediatric delirium is an acute brain dysfunction and it's a significant burden in the ICU. It can be a hyperactive, hypoactive, or a mixed type. And now they have shown that there are modifiable risk factors which can be identified and corrected so as to reduce the incidence in our given ICUs. It can be diagnosed with validated and reliable bedside tools, so you don't really need a psychiatrist for every single case. 80% of them can be identified with screening tools, and it has shown good concordance between the nursing assessment of delirium with the CAPD scores and a psychiatric assessment in Chani-Trop study. It can also be managed with early identification through screening, correcting underlying illnesses, and use of simple clinical pathways as above. So it is a problem that we need to look at, problem that is very prevalent. And hopefully, now on, we're taking it proactively so as to improve our critical care outcomes. Thank you everyone for patient listening.
Yeah, thank you, Dr. Reena, for that excellent presentation. Now we are open to take questions. Please be free to ask any doubts or any questions you have with regard to this topic on pediatric delirium.
Hi, Dr. Reena. This is Dr. Aparna this side. Am I audible?
Yes, very much.
This might probably be a very simple question, but just for the sake of clarity, so how do you assess sensorium in a child who has neuromuscular paralysis, where assessment of motor functions may be impaired, and in a child who is on assisted ventilation device, where again vocalization may be a problem?
Okay. So in a neuromuscular paralyzed child, the RAS scoring will anyways be -4 to 5 because the child cannot be aroused. He won't be able to respond. So in these children, to identify the consciousness, a sensorium would be difficult. In a patient who is not able to vocalize, there are other scales, that is your comfort behavior scales or other sedation scales, which can be utilized because it is not just based on your vocal response. It's based on the general response of the patient, of the physical response of the patient. But in neuromuscular paralysis, it is very difficult because they will score much lower on your RAS scale. So most commonly, the RASS score itself is